Good morning and welcome to Mount Sinai Heart Peripheral Vascular Intervention webcast once again. This is the fourth Wednesday of this month and we're going live again with an excellent case of aortic and iliac intervention. Just before we start, I'd like to say a few things for those who may be logging in for the first time. During the case, you can send us any comments or any questions at the email address info@peripheраlinterventions.org, and we are going to answer them or address them during the context of the case. The next case is going to be on August 22nd, the fourth Wednesday of August, same time at 8 a.m. Eastern Standard Time of the United States, or anywhere else you are in the world, just exactly the same time as today. And remember, if you missed any of the earlier webcasts, you can just go to the last cases link and you can see one or all of them either later or anytime you wish. We upload the case as well as a related lecture every month. Without any further delay, I would like to introduce a cath lab team, Dr. Krishnan and Dr. Wiley, two of today. Welcome and congratulations for a brand new outfit, Dr. Krishnan. What is going on with this machine over there?
Good morning, Dr. Dangus. Before I get to that, I'd like to introduce the team. We've got our nurse, Elizabeth, here. We've got Ricky. We've got our fellow, Rohit, and Dr. Wiley. This is the new zero gravity outfit that we've been given thanks to Dr. Sharma's generosity, which prevents the radiation levels from being high. I'm not wearing any lead right now, nor a thyroid shield, and we're checking. We have no radiation from so far that we've been checking our meters. But anyway, back to the case. It's very flexible, as you can see. You can move around, and obviously good for your back and legs. So we've got Dr. Wiley is going to present this case, and then we're going to talk about a little bit on the strategy. Jose?
Does Sylvester Stallone has one of these outfits as well?
I mean, last I heard, the Iron Man movie was actually utilizing this, but I don't know about Sylvester, although Sly will probably get one soon.
Matrix or something. Great.
No, I think it's the Iron Man. I forgot his name. But go ahead, Jose.
Hi, good morning, everyone. This is a 78-year-old gentleman with past medical history of coronary artery disease with prior multiple PCIs, hypertension, hyperlipidemia. The patient had a known CVA. He was complaining of bilateral Fontaine Class II claudication, that is, claudication occurring at less than 200 meters. We had done a peripheral angiogram a while ago, which showed a complex distal aortic and right common iliac severe stenosis. The plan for today is going to be a percutaneous intervention of the distal aorta and iliac artery.
Now, George, this guy is followed by one of our partners here in clinic, and he basically has been complaining about buttocks and thigh claudication for the last few years. He's got it bilaterally, and he can only walk about, let's say, 200 meters before he has to stop. He's an ex-smoker, and as Jose went over, he has significant coronary disease, et cetera, et cetera, et cetera. So the bottom line is, we went and got a CAD scan angiogram after, an MR, and the MR showed at that time he basically has complex distal aortic disease, normal SFAs, complex iliac disease. The MR surprisingly showed that he had bilateral iliac and actually distal aortic issues and severe right common iliac access lesion, or I should say aortoosteal lesion. So what we did was we brought him in today with the plan of fixing the distal aorta into the iliac, and then we did an angiogram. Now, interestingly, we did an MR because his creatinine is high. We got the AOK from our nephrology colleagues after they looked at him and they followed him. Give me the second transducer. So what we did was we went ahead and got bilateral access with the initial plan of going ahead and doing it. Now, interestingly, he has absolutely no pulses. And so on the right side, so we had a lot of difficulty. Flush, please. He had a lot of difficulty getting access. We'll keep flushing. So we got access, and then we actually got left access as well as right access, and then went ahead and did our aortogram that you see here. The aortogram here that you see actually shows, that's perfect, actually shows actually seen minus, Jose? We did a distal aortogram as well as a full aortogram. Minus one more. You can see here with, Jose will pause it as you see all of it come down right there. Pause right there, please. Great. So you can see the very ratty distal aorta, infrarenal aorta with multiple areas of stenosis. And then you go ahead and see, obviously the renals are fine. And then as you come down further into the distal aorta, you can see like a slight, I would say, ectasia of the distal aorta proximal to the aorta. But proximal to that ectasia, you go ahead and see a little narrowing. And then you go ahead and see, plus please, the ostia of the common iliac, at least angiographically, does not look any significant. Okay, plus please. However, you can see on the right side, there is extreme tight narrowing of the common iliac in two different areas. One, right at the level of the distal aorta, right proximal to it. Second, just below that, you can see there's another narrowing. And then below at the bifurcation of the external and the internal iliac also. On the left side, so what we started doing was checking pressure gradients, which is what we should do. So can you show me the pressure gradient here, please?
Yeah, that is great, and I would like to indicate also that the appearance of the angiogram is a little suspicious for the aortostial of the left common iliac as well. That's why, and also I'm curious to see what the gradient would be across the aorta. Let's say from the level of above the renals until the level just above the bifurcation, just to have an understanding of if that diffuse aortic disease has a significant pressure gradient on its own.
Right. So what we did here was, I want to show you two different pressure gradients. Okay, that's it? Fine. We're fine. So this is if you show the pressure gradient here, this is on the left side with the catheter above, as you can see here. I'm going to fluoro for a second, okay? And I'm just going to see the catheter is above.
Show us an insert, please, the angiogram and
there you go. So right now the catheter is on the right side, okay? Exactly. It's above that lesion. Jose, just a little squirt. We're going to give a little bit of dye just to show you where the catheter is. So it's above that narrowing. You see that? So it's above that second narrowing on the aorta, okay? And flush it again, Jose. Now we're going to flush it. And that's fine. And our iliac catheter is well below here on the left side. I'm just going to focus on the left side. So now you're going to show us the gradients here. And you can see here as the gradient comes back after Dr. Wiley has just flushed it. I think you need to flush a little more, Jose.
You want to open both to zero as well to demonstrate the well balance and
we're going to zero both.
Demonstrate the standard
we're
way
zero both, please.
For doing gradients for everybody.
Yep, exactly. So we're zeroing both now. So both are being zeroed. So you can see here by the line, they're both zeroed. And I think this is very, very important as we go forward. You can see, I don't know, I guess they're not both zeroed. We need to zero again, guys. That does not look zeroed to me. We just had a good gradient. I don't know what happened. Okay. All right.
So red is which pressure?
Well, the red is aortic pressure, okay, which makes absolutely no sense since we are, unless I moved the catheter. Yes, I did. See that? There you go. See that?
All right.
So now we got red in the above the second area of the aorta, as we saw. And now I'm going to pull that catheter down. It's a pigtail catheter. So I'm just going to come down slowly. I'm going to come across.
Yeah, let's stop over there just to see that the aorta itself has no gradient.
Exactly.
So
that's the point.
First important observation here.
Aorta does not have a gradient. So therefore, on the left side, I don't think I'm going to have to fix the aorta. Now I'm going to switch over to the right side. I'm going to show you the gradient from the aorta down. Okay. Flush forward. Ricky, I need to flush forward.
So the previous, the one that we just saw, about 20 millimeters, was between the aorta and the left external iliac.
Exactly.
And now we're going to see the aorta against the right external iliac.
And there you see it right here. I'm going to pull the sheet back a little bit further just to make sure I'm not in that internal-external bifurcation. And now you can see here, just from the, we know there's no transaortic gradient here. and you know that you have approximately on the left side that you saw approximately a 50 millimeter gradient. On the right side, you have a 60 millimeter gradient across the common iliac aortic junction, all the way into the external. So in this particular guy, now he's got an MRA positive, he's got CT positive, he's got an angiographic positive, and he has hemodynamic plus symptomatology that's positive. So now when Dr. Wiley is going to show me the angiogram again, scene minus please, the point becomes is, well, how are we going to fix this guy? And that's why we brought him to the lab to demonstrate. So here you go. You've got probably the iliac radium is right at that ostium. You can see the little bit of a narrowing right at the level of the ostium once we freeze it. And so what our plan here is going to be bilateral stenting of the distal aortic bifurcation and or adding a stent on the internal-external bifurcation on the right side. On the left side, it looks like we're just going to need a focal stent that's going to extend into the distal aorta. Right side, we're probably going to need a little longer stent that's going to extend into the distal aorta. And then hopefully, if it's long enough to cover both the external internal bifurcation as well as the common iliac lesion. At this stage, we've given our anticoagulation of choice has been heparin. And I believe we always go with heparin. We give weight-based dose, and our ACTs right now are around 296 to 300. And so we've got a good ACT. We've got the CTMR, and I think part of the discipline of what you need to do is to make sure you have good distal runoff prior to, and because of his creatinine, we have not taken a full distal runoff, but I encourage everybody out there who's going to do this to make sure you know what your distal vessels are so that, God forbid, you trash, especially from an aorta such as this, down into the foot, that you clearly know what the distal vessels are. So in this particular case, we may do a completion angio. I doubt it because the creatinine is high. What we will do is probably follow him clinically. But at this stage right here, we do have an MR earlier on. I'm a little worried about creatinine because his creatinine is around 1.9. We may do a shot at the end just to see how it looks all the way down to the foot, depending on how much dye we use. The second thing is, as far as the sheet size, we went with 2 7 French pinnacle destination sheets with marker ends. And the reason we did that, can you start opening the balloon, guys? 2 7/0 balloons. As we start, the reason we did that is because if we need to go ahead with covered stents, we can take 2 8 millimeter atrium stents into this vessel without a problem. Number 3, if we need to balloon occlude this with either a large balloon, if we perf the iliac, we have the ability with a 7 French sheet to go ahead and balloon, and we have complete access. Our wires
let's stay a little bit into this.
Sure.
You can minimize my picture into this so you can still see the cath lab. May I ask the following? Going to be very clear because I think the viewer is not very familiar about what is the maximum balloon occlusion for the aorta that we can fit through a 7 French?
Well, no, George. 7 French is not. I'm not worried about perfing the aorta here.
No, I understand, but let's clarify those things. I think we can through a 7 French, you can still put a decent sized balloon on the 14 or something. If you need a coda balloon, which is a very big balloon, up to 25 or something, then you need a little bigger sheath. But the most important aspect is that any covered stent will fit in the 7 French sheaths. And many people actually, PK, will do this case with 1 or 2 cover stents from a get-go.
Yep, exactly.
There's some believers there that there may be a stenosis benefit and all that. I'm not sure the data are very clear on that, but indeed it is possible to just from a get-go to do, let's say, the right with a cover stent and the left without, or 2 cover stents as well. You can use the atrium stent for that.
Right. The problem here, George, is really going to be what is it called? Is going to be if with the covered stent. I'm sorry, I lost my train of thought. With the covered stent is going to be that you're going to be hanging into the aorta. So therefore, what Jose, Dr. Wiley, and I decided to do here is to go ahead with 2 self-expanding stents. First, we're going to balloon the lesions very well and make sure that they expand, especially on the right side. That's our first step here. So I'm loading it just an undersized balloon. Jose, can you go scene minus and put it up on the right side? Yeah. I'm just loading an undersized balloon here, and I am going to go ahead and just save it on the other side, please. Great. All right, wonderful. So now what we've started doing also is to look for angiographic marks. Now I want you to look at the dot on the supracoronary wire on the left side, which is in the heart of the common iliac on the left. Now that pretty much correlates to my lesion, my ostium of the right side. We know we're going to extend the stents above, but I want you to understand we're not going to have any dye, first of all, for the reason of not knowing. And you can see right there, my dot hasn't moved. As long as my fellow, and we always blame fellows, that doesn't pull the wire back, we're okay. So now I'm just going to go with this at this level. It's a 7mm balloon, and we're going to go up. Now the two things that we're watching for is very, very simple, is pressure. We're watching for pressure, okay? And the pressure we're watching for is our sheath pressure. Can you flush the second transducer, please? Is our sheath pressure, and I've got pressure on my left iliac as well, okay? So we've got two pressures to watch for. Perfect, thank you. So if the patient's pressure starts to drop, then we know exactly what happened. Why is my pressure so screwed up, guys? My left pressure, oh, there it is, okay.
It's moving.
It's my fellow again, okay. So we're gonna go ahead. Right now, Dr. Wiley's gonna balloon. You can see I've placed it approximately at the level of the ostium. It's a short 7mm balloon. Go up, please.
720. We're 2.
You can see how tight that distal lesion is down, and you can see how it came back. So it's very, very calcified, and we are clearly, in for it today. Okay, go up again. So I went with a focal balloon to hopefully that it does not watermelon seed, and you can see here, guys, it is a tight, tight lesion. Okay, slow. Okay, keep going. Okay, good. Now all I'm looking for here is George's expansion of this lesion. We know it may be undersized, but I want to crack it, and that's all I'm trying to do here. So I've cracked it now. I'm just going to put this on Cine Fluoro Save. I'm gonna leave it up. Okay, I'll just Cine it since I'm not close to that thing. So we're gonna leave it up for a few minutes, and then allow the balloon to really expand. Go 5, please. Okay, nominal is about 6, so we're gonna leave it around 5. Okay, and then down. Now when we come down, what we do is we watch the pressure. Okay, if the pressure drops precipitously, we know we have a problem. We know we've perfed. Now, if you can see the pressure on the white is the right side, red is the left side, you can see our pressure in the white is now moved up, and our gradient has gotten a little bit smaller, approximately 30mm from the right to the left.
Yeah, we'll have already an improvement there.
Exactly. So now what I'm going to do is I'm going to walk this back because I know I have 2 lesions, right? So I'm going to go up right here. Dr. Wiley is going to go up right here, which again, I'm correlating it with my my dot on my left supercore.
Just 2.
Yep, 3.
Yeah, no
4.
issues there.
Okay, there's no issues there. Down. Can I walk it back, Jose? Give me a little injectable dye, guys, for me. Actually, no, we can inject for this.
So you probably got to do now the
common
bifurcation
external,
of
yes.
iliac.
Little dye, Jose?
I bet you this is going to eliminate the gradient.
Wrong side. Okay. This side, the other side.
The other side.
Oh, give me some dye, guys. Dye in a bowl, please. So unfortunately, we haven't set up 2 transducers. We have, but not 2 injectable transducers. So now we're gonna inject through the sheath just for us to see. Okay. So now you can see the pressure is almost eliminated, but we'll just give it a little shot. So I got to go. See that lesion right there, George?
Yeah.
I'm going to have to go up a little bit further. Flora, please. Okay, go up now, Jose. So Dr. Wiley's going to go up here.
We're at 2.
2, 3,
3.
4. That's it.
4.
So you can see now we've got a balloon up in the external-internal junction with the common, and now we're going to leave that up for a few minutes as well. And again, it's very important for the audience to realize we're doing a hemodynamic, relief of this man's symptoms. The reason why this man is so symptomatic is because obviously the external, the common and the internal iliac supply the buttocks and the thigh muscles, and therefore that's why he's so symptomatic. Down. So we want to relieve the gradient. Again, I'm going to leave the wire up at this stage. I've got 2 pressures, and you can see that the pressures are almost equal, and they're equal. You can see here as the balloon came down, you got a little bit of a 5-7mm gradient, a little drop in pressure, which is worrisome, but not really. And I think we're going to go ahead and just walk this balloon out. The other thing we do is we don't detach the balloon. In case we perf, we go ahead, because sometimes the perf can be held open with just the balloon. And what we do is we just go ahead, walk the balloon out. We do not lose our wire position, and we don't detach. Now at this stage, I'm just going to inject again from below. Again, my pressures are very good. I feel very confident. And then I go ahead and just take a picture from below. It's going to look really bad. but maybe not. Okay,
Oh, maybe not. Maybe it looks really good.
Right, and you can see you have a pretty reasonable, looking common external internal bifurcation. Got a bad dissection on top heading into the aorta, but that's okay.
Yeah.
What we're going to do now is we're going to do two self-expanding stents. We're going to do two self-expanding stents extending into that distal aorta. Okay, just past the bifurcation. We know we don't have any SFA disease. We know that we don't have to come back and fix this guy by an up and over sheath. If he does get critical limb ischemia or anything like that, God forbid, then we're going to have to go ahead and go an antegrade approach. But at this stage, I think with this symptomatology the way it is, we're going to put two self-expanding stents across that distal aorta and then land them both into the common iliacs.
Now, before we go further, Piquet, this is a nice time to take a question from the website, and it's a little bit not related about any specific step here, but the general comment. We see the aorta has a lot of radi disease, diffuse disease, and you also told us the patient had an MR or a CT. So let's say the CT shows quite a bit of thrombus in the mural thrombus in the aorta. In what way would that affect the procedure?
Well,
without everything else being the same, so to speak, as we explained it.
Well, I think with the mural thrombus, I think you're kind of forced to use a covered stent. But when you have the distal aorta involvement, then you're talking about possibly getting into an aortic cuff. You're advancing the wire. We can't lose that wire. Okay, aortic cuff. Oh, you pulled the wire back. Great. With the aortic cuff, it's very important to maybe use an aortic cuff here to be able to, do the distal aorta and then reconstruct the iliacs with some stents. That's how I would do it, George. I would worry about embolization of that distal aorta down, and then therefore I would use a distal aortic covered cuff, and then I would go ahead and fix the.
There are indeed some devices of, I would say, probably the Endologics aneurysm device is. Can sit at the bifurcation of the aorta. That may be good for a case like that, but this means that the mural thrombus of the aorta is of some significance, and maybe the patient has a little bit of a borderline aneurysm. The other possibility is that you just try to not intervene or advance any devices in that area, and just leave alone, so to speak, the atherosclerosis and the mural thrombus of the aorta. If this is, let's say, mostly in above 10 millimeters or 20 millimeters above the aortic bifurcation, that doesn't interfere with the stents or anything we do, then you just, accept it and just treat it medically. Great point, though, because if people are doing CT or MR for to work up, those things, they're going to see something more than just a lumen, and they got to be able and ready to react, so to speak. That was a great question and a great teaching point.
So now what we're going to do is we balloon the left common iliac, and now I'm just going to take one picture, which we're going to work off. Fluorophate, please. So we're just going to go with one picture. I'm sorry, I was going to fluorophate. So I'm just going to do it on the road map here, just so we can see. So I gave a 20 cc injection. Now we're going to just work on the roadmap. So I need, as far as the stents are concerned, George, I'm very aggressive. What I'll do here is put in two either 12 or 14 millimeter stents, to handle the distal aorta down. I think with self-expanding stents, we don't have much of a problem. So I don't know if you guys or you or Dr. Wiley have any comments. I probably will go with two 14 millimeter 60 stents here. Distal aorta down, and then stent the right the right external internal junction with another self-expanding stent if needed.
I was going to say, why don't you just take like a I don't know if the 14 comes in 100, but the 12 may come in 100. Maybe you can take a couple of 12s in order to take one stent to cover both lesions on the right. Is that possible, you think?
As far as I know, with the stents that we have in our lab, which are the EV3 stents, we have 80 is the largest 14 that we have. So building on that, we'll take one 1480 and one 1460, and then if needed, we'll go ahead and deploy a second stent on the right common. Can you get one 1480, one 1460, guys? Now, George, I think at this stage, I mean, it's very important for the nursing part of what we do to be very much involved. We've got ACTs. As you saw, Elizabeth has been speaking with our patient, seeing how our patient's feeling. Because a lot of times, subtle symptoms, elderly people will think that, it's part of the procedure. They don't want to be bothering the doctor, so they won't tell you that they're having a little bit of back pain, that they're having a little bit of discomfort. So therefore, you clearly want your nurses to be also aware of the signs of impending perforation. As you know very well, the signs of impending perforation are bradycardia upon balloon inflation, which is very important because, again, we've talked about it earlier with subclavians. You clearly can have stretching of the and irritation of the adventitial nerves, causing a vasovagal type effect. The second thing that you need to worry about is obviously profound hypotension. Never take it lightly in an iliac. You know that obviously there's something that's gone wrong, especially in a patient who's been stable throughout the procedure.
Yeah.
The third thing, what I worry about is any sort of pain. I mean, they will have a little pain, but the pain should go down once your balloon goes down. Tell them not to move, Liz. The pain should go down once your balloon goes down. So if the pain is still pertinent, oh, look at this, George. Look, it's going to cover beautifully. 14080 is actually perfect. It covers both. I'm actually going to go up a little. Am I too high here, George? Should I go with the 60, you think?
No, I think it's okay. I would just leave it there. I think once you use a self-expanding stent, I think it is a good idea to cover that little funnel of the distal aorta.
Okay.
And you're going to really finish them, proximally exactly where the aorta lumen is as fat as possible, which is, by the way, it's exactly where you are.
Exactly.
So that's a good way to land that.
Yep, I may even go up a little bit just so I don't pull back when we deploy these. And we're going to have to deploy them, Dr. Wiley and me together. So we will, I know there are a lot of guys who do dual deployments.
Yeah, let's position both, and then, let's put them both ready. And, that's an important point for the audience, that the stents have to be positioned first, and, multiple pictures will be taken. You have to make sure that they align very well with each other in the proximal part.
So as I was building on the perforation thing for the audience, you need to let this wire go around the soft part of the wire. See that it's also important now to work on the stiff part of the wire. You see, I saw the dot in the supercold wire, which again tells you, the marker tells you, I keep calling it dot, the marker tells you that you are on the soft part of the wire. So here, we'll go ahead and advance it a little bit further, say up to there, and I want to make sure that I am on the stiff part of both wires. So what I'm just going to do is push the wires up a little bit, all right? That's the stiff part of the wire, and I know I'm the stiff part of the wire with the left. So now I've got both stents crisscrossing and placed, and you can see this really precludes us from ever going up and over, So now the issue becomes is multiple pictures, so I'm just going to take a couple of pictures. Again, it's creatinine being a major issue. All fluorofade, guys? I'm just going to take one, no, don't move. I'm going to take one shot, okay? Just a little lateral, just to make sure that we're not missing anything here, right, in that kind of picture. And I'm more concentrating on the right because I know I have a distal lesion that I have to cover. And again, this is where the 7 French sheet comes in handy, because the 7 French sheet, I'm not strong enough, unfortunately. I didn't eat my Wheaties today. No breakfast. Okay, no breakfast. So the 7 French sheet will allow inflation, but again, we've placed it on the fluorofade. I'm pretty happy. We're covering the distal lesion. I think we're going to go ahead and just deploy here, George.
Yeah, the important thing is to verify you're covering the distal, and you show that very nicely. I think proximally you're okay where you are.
As long as it doesn't come back, I think we're fine. And I think we have room to go forward a little bit, and I think we're going to start deploying. So Wiley's going to take the other one. You need to, yep. All right, we're going to work together. We're going to flare it first together because we can adjust it once we flare it. Right, Dr. Wiley? Okay, I'm starting. Okay. Okay, you're pulling back. You need to go forward. Stop. So I'm going to move Dr. Wiley forward a little bit. I want to keep our dots together. Very important to be keeping those dots together, right? I'm going to come forward. As you can see, good teamwork. Okay. I'm adjusting as we go. Okay. Go ahead. You flare, Jose.
Okay, you got to adjust them a little bit better over there, Jose.
Yep, Jose's adjusting. Don't move, sir. I'm already flared. Pull down a little, Jose. Pull down, pull down.
Got to pull down, yeah.
Now flare.
So adjusting, as you see, is very tricky, but it can happen. Yeah, I think that's a very good.
Good flare. Yep. Flare.
All right.
Okay, we're both going to release now. Okay, now it's the point of return. So we're just going to come back and bang.
I think you recreated the funnel very well.
Yep, and you've got that distal area which we're going to have to balloon, which is fine. Walk it back, please. So it looks kind of funky now, but we're going to go with 2 balloons, and we're going to balloon it open, and things are going to look really good. Don't lose the wire. Now, this is the key, guys. You cannot lose the wire till you go ahead and balloon this out. Huh? Yeah, there's no gradient. And nurse is pointing out how there's absolutely no gradient here. So now, I'm letting them walk the balloons out. So we're going to walk the other balloon, please.
Yeah, remember this is a gradient between the left and the right
External.
common external iliac, so we kind of equalize both legs.
Right.
But still, there's about probably a 10 or 20 from the distal aorta, and you know, we're going to optimize that by the kissing balloon inflation.
Yeah, I think here we go with 2 7/0 balloons. I'm holding my sheath as Dr. Wiley walks it out. Again, the key is not to lose the wires. And also, these are self-expanding stents, and the problem with these stents that we use, they've got open cell design, so it may be difficult to get the balloon through. So you need to have a stiff wire and a little bit of shimmy to get them through. So now I want to go with 2 7/0 balloons. Two
All right,
new 7/0 balloons.
Now we have a question, 2 questions from the audience. The number one is, what is a pressure gradient cutoff to do an intervention, to begin doing an intervention, and what could be what result are you looking in the pressure gradient?
Honestly, it's a phenomenal question. What we do is we obviously do clinically during 2 7/0 40s are fine. What we do clinically is we go with a 20 millimeter pressure gradient. The 20 millimeter pressure gradient is actually the one that's well accepted as far as in terms of what the interventional community is using at this stage to go ahead and do it.
20 millimeter resting gradient
Yes,
is exactly the...
Exactly, and I thank you, George, for that.
We don't have the capacity to exercise in the cath lab, so we assume that if you have a 10 or to 20, specifically, it's going to go even higher with exercise.
60 goes down.
There's 60 on the right and 40 on the left. So what we decided to do was go with a 7/0 60 on the right and a 7/0 40 on the left, extended to the aorta. The second thing, George, as far as when do we stop, that's a great question, because the major issue here with when do we stop is that you don't want to lose the patient for the sake of a gradient. So what I teach my fellows is if you have a heavily calcified lesion and you're ballooning it, and the patient is bradycardic and having pain, and you keep on ballooning it, you have a little bit of recoil, and you've reduced a 20 millimeter gradient to a 5 millimeter gradient, hey, you know what, that's time to, get out of Dodge. You've done a good job, you've gone ahead, and you've reduced the gradient. The patient is clearly going to feel much better. So what we'll do at that stage is just get out of Dodge and not worry about it. You can see here we're going to take it all the way up to that spot now with the balloon. So again, a lot of judgment is necessary. So can I have another one, please?
Yeah.
Obviously, the left side needs a little bit more ballooning than the right side. So I think that's expected. Actually, we did a lot of work in the right side, not as much on the left side because there were the 2 lesions, etc. We're more concerned about the right because the lesions were tighter and the gradient was higher there.
Right.
But again, one can see now that when the stents are deployed, that where the real lesions are, you can see very clearly that the ostium of the left common iliac was really very tight.
Which we actually had ballooned. We actually had ballooned that, and we obviously didn't expand it, which I'm not too worried about. Because I have a feeling that here with the distal aortic balloons here, now we've got important to have 2 hands, and we need to count together. Very, very important. We're ballooning in a distal aorta here. We want to work together. We want to have our nursing staff, everybody together to know what's going on. So obviously it's a diseased distal aorta. Again, we've abolished our iliac gradients here. We just would like to get a nice result, open up these balloons. So usually what we do here is count together. So we go 1, 2. It's almost rudimentary. It's silly to some people, but it works really well for us. So we're going to go 1 together. The reason I chose 2 7s, George, is that the distal aorta measured 18 on the MR, and I've got 2 14 stents. I'm undersizing my balloons. I'd really kind of just want to get the 2/3 rule that we use in coronaries. Keep going up 2 to 2/3 rule that we use in coronaries. 3. So we want to all be together here. 3 guys. Okay. Now you can see George is very nice. I'm going to go up to 4. 4. Okay. Now I want the left balloon to go to 5. And I'm pretty happy there, George. We got a nice expansion of that. We've got the little distal aortic flare that we were looking for. Our pressure gradient, maybe just take the left to 6.
6.
Okay, and that's nominal. So you can see here, we're just going to leave it up for a few minutes. At this stage, the patient may feel some fullness in his back, which is to be expected. The patient, is not bradycardic. As you'll show the hemodynamics, guys, the patient is not bradycardic. We have some pressure, which is okay. We don't want to be completely occlusive. We really just want to kind of expand it. And then now we go to, we're going to leave it on. He's doing well. Down, together, down. So now you see we go together down. We have a little bit of residual on the left neck. The left pressure came up. Obviously, the right's a bigger balloon, so you can see how it looks. Now we're just looking for the equalization of the pressures, which we clearly have. Now what I'm going to do, George, is something interesting. I'm going to leave the left balloon there. Dr. Wiley's going to walk back the right balloon a little bit, okay, a little bit more. Okay, I'm going to have Dr. Wiley go up alone here. Go up, please, so I can get this part.
Yeah, it's a very important step here because you also have another lesion in the right, so
exactly.
you have to
and we're
dilate that.
Yep, exactly. 2, 3, 4. That should be good. That should be good.
And I think that one can see here that the self-expanding stent hasn't really been expanded to anything more than a 7. The 7 balloon kind of fills very nicely the stent pretty much in every area. So I think this is a pretty good size.
Well, the other thing also, George, is that we wanted to make sure that we would get the distal. I'll go up slightly here, just slightly. Just want to make sure I flare the open. I just wanted to make sure that I fit it into that distal aorta, so it looks nice, Slow. Okay, 4, 5.
I think it's good.
Okay. So now I've got both edges flared. Now that's important because this guy obviously has CAD, is going to have multiple cardiac catheterizations. You want to make sure that we go ahead and get all the access points to be very, very nice for him. So the pressures have equalized, as you can see. Now this is called sheathing the balloon. So I just want to sheath it here, and then I'm just going to go up with using the balloon as my dilator, right? And I'm just going to push the stent up, my sheath up. Now I've got clear access into the distal aorta if I perf. Okay, now if I have a perf, if I have a drop, you want to go ahead and sheath the balloon all the way up into the distal aorta. Now I've got complete access of this aorta. If I need to go do whatever I need to do, if God forbid the guy's bleeding, things are going bad, you want to have access across those stents. Because now you have 2 self-expanding stents, and the access point across with large, bulky balloons will make it difficult. Now I've gone ahead and put this up, and if I need to now to walk this out and try to get a balloon through, I'll get a balloon through this. I can get some balloon to be able to go ahead and stabilize the patient, especially with 2 7 Frenches across. Now, I would do the same with the left side if I needed to, but obviously I don't need to here, so I'm not going to mess around. And this also demonstrates the importance of ballooning the entire stent to go ahead and tack up the self-expanding, the open cell design of these stents up against the wall. We learned that with the carotids, with the EV3 system, with the open cell. Sometimes it's difficult to get the filter retrieval device up, and I think that's an important part of your algorithm to go ahead and think. So currently now the balloon is partially in, partially out, so Dr. Wiley's going to walk the balloon back into the sheath. And again, we're not going to detach. I really want to teach that discipline. We don't want to detach. I know people will say, oh, you guys are paranoid. Yeah, we are paranoid because these are procedures where we could really hurt the patient. So we're going to walk out, we're going to go ahead, take a picture. God willing, everything is okay. We all can smile and go, and we want to make sure. The other thing is the reason I didn't balloon that distal aorta, especially at the level of the ectasia, is that these are 2 14-millimeter stents. I don't want to have balloon overhang going and dissecting my distal aorta. Now I'm dealing with an edge dissection proximal to my stent. So I kept the stents well within the balloons well within the stent margins. Now I'm going to go ahead and inject above, right? And is it perfect? No. Because to me, I'd like obviously everybody wants that wow result. This is a very good result. The stent is well opposed against the distal aorta.
I think it's an excellent result given the fact that there is a lot of diffuse disease in these aortoiliac vessels throughout, and I think the stents very nicely can have flared in the distal aorta.
Right.
So you have a good coverage of the both ostia.
Right.
I think it's a very good expansion. I'm pretty sure there's no gradient. Actually, you can measure now the gradient because you have a above and below. There's maybe a 3-millimeter gradient or something.
Right, and you have
gradient.
that's actually a wonderful point, George, what you just said, because now you have a gradient. You have the right catheter above the iliac stents and the aortic stents, and you have a left catheter is in the left iliac. and absolutely maybe like you said a 3 or 4 millimeter gradient, actually about a 6 millimeter gradient that's happening. So I think that's okay. I think he's going to be do very well.
Very good. I have a question over here from the audience, and this is regarding the angioscore balloon, angiosculpt balloon. I would say this is a balloon that has an external wires in that it allows you not to slip that much and maybe provide a more durable angioplasty result by creating a controlled dissection or scoring, so to speak. This is mostly used for standalone angioplasty or for instant stenosis, so I'm not sure what the role might be for here. I don't see much role for this type of a procedure. PK, do you feel otherwise, or what do you have to say regarding use of a scoring balloon?
I'm going to ask Jose to answer that one. What do you think, Jose? What do you think?
I think it's really not necessary in this particular case. All we want to do is to crack the plaque. There's inherent risk of a perforation with scoring balloons or cutting balloons, as you saw in this case. Just inflating the balloon to nominal was enough to open the vessel to where we wanted and bring down the gradient to less than 5 millimeters of mercury. So I don't think that we needed that extra risk by using a cutting or scoring balloon.
You know, and building on that, I think his point is very true, is that the risk of perforation may be higher. There, you know, as far as cutting balloons in the iliacs, Dr. Daniels, what we do is we use it as far as in terms of in-stent. I know that you've done a lot of that when God forbid, you do have an in-stent of these iliacs in a rare situation because the restenosis rates are so good that a cutting balloon may be a good thing. The second thing where a cutting balloon may be good is if you have an extremely calcified lesion. You know, but the worry there is perforation, but at least you can score it a little bit and hopefully are able to expand it with your second balloon inflation.
Now, a good example of a case that one could consider that is exactly as you say, the instant stenosis. So take around, there's a diffuse disease, some, you know, let's say a year or so later, there is a focal lesion within any of these stents. That might be a good indication for a scoring balloon, especially since we know what balloon size the patient tolerated before. So that's another knowledge one could have for instant stenosis, because you have a 7 millimeter stent or 8 millimeter stent, automatically you know that you know, the patient, you know, you read from the chart, the patient tolerated well a 7 or 8 millimeter balloon inflation, and therefore that gives you a good guidance of what kind of size is going to be okay for that patient. So therefore, again, for an instant stenosis, and with the knowledge of prior, you know, sizing, the angioscore can be helpful. But otherwise, I would be very concerned about it and avoid it in the case of a de novo common iliac lesion.
Exactly. So in summary, I want to summarize what we feel, at least at Sinai, Dr. Dangas, myself, and Dr. Wiley, in terms of how we would handle these lesions and our thought processes are concerned. I said, first of all, I think the stress of this is it's a hemodynamic disease. It's very important for everybody out there to decide where the lesions are that are significant, especially in a diffuse aorta, a diffuse common iliac, and a diffuse external iliac. So you're going to have multiple areas. Unfortunately, we don't have FFR and all those wonderful coronary tools that all of us here are used to playing with. So here we're going to go with rudimentary gradients, but it's important here to go ahead and do that. So it's important we check the gradient across the distal aorta, as you saw. We then checked translesional gradients from the distal aorta into the right and left common iliacs. And then we checked from the common iliac or the aorta into the external iliac to show that that was also significant. So that's the first step. First is the hemodynamic nature of the disease. If you start stenting lumps and bumps, you're talking about stenting the entire aorta all the way down into the iliac, so which is not what we do here or anywhere should it be done. So that's one. Number two is to go ahead and decide your approach. If you are going to involve the distal aorta, it is probably prudent, in our opinion, I'll just ask George after I'm done what his thoughts are, whether it's good to go ahead and get dual accesses. But here, Dr. Wiley and myself have always believed that we go ahead and get dual accesses if the distal aorta is involved. If the distal aorta is not involved and we have an aorto-ostial lesion with a normal left common iliac and a good angle to go ahead and stent, then both of us have gone with balloon expandable stents without having contralateral access. But again, if your angle is bad, what I mean by an angle is if you have a 90-degree angle going from a right common iliac into a distal aorta with a left common iliac that doesn't have a 90-degree angle, so you have a very narrow we have a very wide bifurcation, but an awkward bifurcation where your ostial stent may protrude into the left side, you want to go ahead and get dual accesses. So that's important. But in these kind of cases, dual accesses are good because you want to be able to visualize and you also want to be able to do this kissing technique. 3 is type of stent to use. Well, like Dr. Dangus suggested, if there is some clot in the aorta, or if there's a heavily calcified lesion, which you're worried about perforation, covered stents may be a possibility. But the problem there is the size differential between the distal aorta and the common iliac. So therefore, we felt very, very clearly here, all of us included, the 3 of us, is that we feel that a self-expanding platform may be good because as in this case you saw, you can put a large stent that covers that distal aorta, flares open nicely, gives you a nice mouth to go up, and yet large enough, and it's a self-expanding stent, so you don't have to worry about oversizing so much into the iliacs, which are normally around 10, 11 in a male anyway. So here we use 14 millimeter stents, and whenever possible, use a one stent technique to stent. And I thank Dr. Dangus that because I think this is a very nice case demonstration of going with a one stent technique on the right and a one stent technique on the left. Could we have gone with a shorter stent on the left? Yes, we could have, but I think it gave us some play in terms of how to place the stent. The last thing is anticoagulation. I wouldn't say the last. One of the last things is anticoagulation. You want to go with a reversible anticoagulation. So we went with heparin rather than bivalirudin because we're working with a diseased distal aorta which may cause perforation. So that's one. Number 2 is you also want to think about your bailouts. You want to think about what size balloons you need if, God forbid, you have a perforation. Do you have the right equipment in terms of covered stents, so on and so forth. And lastly is good technique of deployment. Yeah, I know that there are many wonderful interventionalists who can deploy 2 self-expanding stents alone. I'm unfortunately not one of them. And I really feel that I think it's good to develop a team and have people who you can trust, where you can deploy these stents together. And you saw the conversation between me and Dr. Wiley where we were talking about you deploy. No, you deploy. You adjust. I adjust. Whatever it may be, but the job gets done and it looks good. And then the final kiss. Make sure you don't oversize your balloons. We use the 2/3 rule when we go into the quote-unquote carina. This is similar to a bifurcation case in the coronary. So if the carina is here 18 millimeters, we went with 2/7 balloons is 14 millimeters at that distal edge. But then we take the 2/3 rule of 14, so of 18, which we're clearly under. So clearly the carina, we weren't oversized with the distal balloons, and we made sure that the distal balloon did not extend into the diseased aorta. So you don't want to have a dissection proximal to your stent. So therefore, you want to think about every single thing. Once you've done all this, you want to sheath that balloon and get that device up into the distal aorta because you may still be fine and you may have a little leak that's not causing any hemodynamic compromise, but now you know you've got a little perforation that you want to take care of. So clearly, you want to sheath that balloon in that technique that we showed, and then once you're up there, you take a picture, you talk about things with your colleagues. We're going to do multiple views once we're off air. We're going to discuss a runoff depending on how much dye we use, but we will probably end up doing a runoff because it's good. It's a good habit to make sure you didn't shower this plaque into the foot because the last thing you need is to wake up tomorrow morning, go see a foot that's a trash foot and be, not that you would have done anything different, but say you embolized a clot into the SFA, that now is going to be a problem. At least you're aware of it earlier rather than later. So, it's important. I think these are the simple steps in my mind. And, I'm just going to wait for Dr. Dangus and Dr. Wiley to finish with any final statements.
Yeah, Jose, any comments? Any comments there?
Yeah, I wanted to reemphasize what Dr. Christian was saying about sheathing the balloon. I think that's very important, particularly as Dr. Christian said, when there's a perforation, not only just to advance the balloon, but it's important to have the sheath up there in order to advance a covered stent. This covered stent sometimes may get dislodged trying to get the stent right into the previously deployed stent. So you want to make sure that you put up your balloon and you unsheath that cover stent inside of the perforated area.
That's great. George?
Yeah, I just want to say that, the different types one could entertain is there are also covered self-expanding stents, but they require larger sheath access, arterial access to be deployed, so that would not be a natural first choice. I think you need maybe a 9 French sheath or something to deploy a large self-expanding cover stent. We had a little bit of a comment about that. A second one can say that if the disease is only in the aortic bifurcation and you didn't have this external iliac, the common iliac bifurcation disease on the right, that you necessitate a long stent, one could also alternatively entertain the possibility of a bolus-only angiomax. Well, that is going to be very quickly reversible on its own because the procedure will be rather short in just deploying the two stents simultaneously. If someone could also consider the 7.0 balloon expandable stents for this situation, in that case you would not go that far up in the aorta. The techniques, as you see, vary a little bit if you want to tweak this and that. But I think particularly for the case we had today, with the aorta having this funnel at the distal end and the iliac having two lesions far apart from each other, I think the only way to finish it off with only two stents was the one explained today. In a very nice way. May I just say, regardless of the patient having coronary disease and obviously needing dual antiplatelet therapy, what would be our recommendation for antiplatelet therapy just based on this procedure? I know that customarily we use a dual antiplatelet therapy for a month, but that's not necessary, and if there's other issues, the patients after iliac stent could be managed with single antiplatelet therapy, in my opinion. And I'd like to hear Jose and PK strictly about that.
George, I agree with you. I think it's just the acute air term in which you need dual antiplatelet therapy. Yeah, I think the vessels, as you saw, are 8, 9, 10 millimeter vessels, and I think they can clearly, do very well with single antiplatelet therapy. The recommendations, as you went over, are very clear that you do need dual for about approximately a month. So, I think a lot of that goes on judgment. I would not be averse to stopping if I needed to for whatever reason because of these stents, because I think they're large stents. The flow across these stents, are tremendous. It's aortic flow literally across these stents. So I would not anticipate any major thrombosis in these particular lesions. Jose?
No, I agree. The data that we're using in peripheral is being translated to coronaries, but in vessels as large as this, single antiplatelet agent is probably the appropriate to use.
Exactly, and especially if the patient is on pleta, let's say, for other type of claudication, further distally, that would not necessitate the patient being on 3 agents for a month. You can stop any of those 3 agents for the first month and then just resume as later on the pletal, as you might have done anyhow, or as indicated for this patient. And obviously the same holds if the patient is on Coumadin for any reason, and I think that would suffice to consider a single antiplatelet agent in a patient being on Coumadin.
Right. Well, again, George, I want to thank you very much for this. I want to thank our team here, Elizabeth, Ricky, our fellow Rohit, who's been great, and obviously Dr. Wiley. I think these cases really teach the basic approach to these lesions, and I think modifications are important, whether it's with covered stents or whatever, but the techniques still remain the same, and the thought process still remains the same. So I think at this stage, I think we're done. We'll take a couple of extra pictures, make sure that everything is stable, and we'll get our lecture booted up, and we'll go.
One final comment, PK, actually, that's the end of the case. You reminded me. How about closure?
That's a good.
That's.
You know what? In these cases, George, I'm still very old school. I don't feel like sending a perc close or an angioseal through this stents, especially the distal edge all the way up. I'm worried about these stents now being endothelialized. So I usually try not to close these lesions, and the fellows always fight me on it. But I think that, I think they know as well that in these particular lesions, I'm sure you could close them if you're very careful. But to me, it's a little bit of an issue, and I think this guy is going to be quite cooperative. His habitus is quite good. Access points are quite good. So I think we'll be okay with just holding this as a manual compression.
That's a good point I want to make about that is that several people have a little of a concern of like compressing a femoral artery distal to a stent.
Right.
And that might include the flow and this and that. I want to say that that is not the case in this one, and not the case for a common iliac stent, because the flow is going to be maintained normal towards the internal iliac. And therefore, compressing, even complete occlusion and compression of the common femoral artery during the sheathing removal is not going to affect in any way the flow through the stent. So that should not really be a problem. The only question one might have, specifically use smaller closed devices, etc., is a patient having a very sensitive or otherwise be concerned about an external iliac stent. In that case, the outflow might be averse and all that. In selected cases of those, one can say that, you know, maybe we ought to close in order to avoid the thrombosis of the stent during the compression. But for common iliac, that is not an issue and is not a question. And you know, especially with all these ratty vessels that you see this patient has with a lot of you know, irregularity and atherosclerotic disease, obviously the same is going to hold for the iliofemoral area, and you know, the maybe simpler to just pull the sheaths when the ACT under 150. So at this point, we don't have any other questions from the audience either. I'd like to thank also myself, my partners here, Dr. Krishna and Dr. Wiley, for this excellent presentation, the nursing staff in the room, and obviously I'd like to thank all our viewers who come in again and again to watch the Peripheral Interventions webcast every fourth Wednesday of every month, exactly at this time, 8 to 9 a.m. Eastern Standard Time, or any other time, wherever you may be across the world. We're going to be back with you on August 22nd, the fourth Wednesday of August. Remember, August 1 is a Wednesday, so the fourth week falls a little bit earlier than anticipated, exactly the same time for yet another exciting case in discussion. Remember to send us any comments at info@peripheраlinterventions.org, and also remember that if somehow you logged on late and if you missed some part of today's case or any of the previous cases, you can log on in the live webcast under the archive cases link at the www.peripheраlinterventions.org, which is a website you are using right now to view this case. Again, thank you for your participation and your attention this time.